All right.
All right. Hello. Hello, everybody. Good to see everyone today. I'll give you guys a minute to get connected. I'm seeing people
Hello.
get there connected. We're going to go ahead and put everybody on mute right now so we don't get any background noise.
Okay.
While you guys are getting connected, we got Rachel on our tech. She will take care of all of that for you. Um, my name is Anissa Mitchell, and I'm with Parkinson and Movement Disorder Alliance, and we're welcoming you today for our Lunch with Docs. Today we have Dr. Ahmed, who is a movement disorder specialist and the medical director of neurology at Advent Health in Orlando. Before we get started on our talk today, we're going to ask everyone to chat their questions. We have a fairly large number of people that's going to be joining us for the program. So if you hover at the bottom of your screen, you will see kind of a little taskbar pop up, and you'll see right in the middle a little box that says chat. And if you click that, you can put your questions there. We welcome you to ask questions throughout the program today. And this is going to be a fully conversational style. So we look for those questions. There won't be any slides. So if you ask for them, I'm sorry, I won't be able to give you any because we are really here just to talk today. So what are we talking about today? We are going to be talking about dystonia. Now, that's often confused with dyskinesia. Sounds similar, doesn't it? The DYS in both of those. So Dr. Ahmed is going to explain this to us, and he's going to really dive into what dystonia is. Some of you may have been diagnosed with dystonia. You may have at least heard of it, but it does somewhat get confusing. So I'm going to pass this off and welcome Dr. Ahmed. Thank you for joining us today.
Okay, thank you for inviting me. I think if some may have you joined in the past on my tremor discussion talk a while back. So it's a very interesting topic, and I was telling Anissa about that this is a very wide topic, so you cannot cover in 1 hour. However, I tried to be kind of brief and maybe more focused on Parkinson's disease because as this is the main condition we are dealing with this group. So let me explain about dystonia and dyskinesia first, so then we can start our conversation. And so, if you ponder on the word, dys means abnormal, and so antonia, which is dystonia. Tonia means abnormal muscle contraction, muscle pulling. It's come from the word tone. Like when is the tonic pulling of the muscles? We call it dystonia or abnormal muscle posture or abnormal movements. Now, dyskinesia is the abnormal, again, this means abnormal and kinesia mean movement. So when people have abnormal movements such as, we call it the dance-like movements, the chorea, the head bobbing movement, that's more like, and then these movements are more faster. So dyskinesia is like faster movements versus dystonia is a little bit slower. So they are similar spectrum, but one movements are, you will see, is a flowing and it's kind of more rhythmic movements versus dystonia is more sustained postures, which can be, come and go, but still they are more sustained and they are more, they will remain same. And in dyskinesia, they come and go more faster pace. So put it in a simpler words. And dyskinesia, you see, mainly this word has been used in Parkinson's patients because it's a levodopa side effect, as we know. Dystonia could be different other conditions, neurological syndromes where dystonia is present. But mainly that when we use term dyskinesia, it implies to either is the levodopa-induced side effects or some drug-induced side effects such as antipsychotic medications. So that's kind of like a little bit background in these two movement disorders.
Awesome. So can you talk a little bit about some of the different types and classifications of dystonia? I'm already starting to get questions like, can it be in the face? I've heard of generalized, focal. So can you get into some of those?
Yeah. So there are different types of dystonia. So dystonia itself is not a diagnosis in a way. It is a symptom. It is a movement. So when we see a patient showing signs of abnormal posture, muscle contractions, we have to think what may be the cause or underlying etiology of these movements. So then we rely on our exam. How the patient is showing any other signs and symptoms which can guide us towards a diagnosis. So the classification actually done in the past in kind of different ways. So we said, we can classify into two types of dystonia. One is we call primary dystonia and secondary dystonia. So the primary dystonia is the condition in which we see dystonia is the only sign. There's no other clinical features in these patients. So their posture would be abnormal, but when you do brain MRI or scan or any other test, they're all normal. So they have no other neurological findings except their posture is abnormal. Now, the secondary dystonia is the dystonia which is due to structural lesions, like, for example, after the stroke, patients develop abnormal posture, or there are other signs such as Parkinson's signs alongside, and or drug-induced dystonia where medication cause these abnormal postures. So these are the secondary types, secondary to something. So that's kind of like two major categories where we classify. We have also made classification of dystonia on the basis of if it's involving the whole body. We call it generalized dystonia, when the whole body is abnormal posture. And it happens in young children's mostly when you see. The other type would be focal dystonia, when dystonia only involve in one portion of the body, such as neck. And that's the cervical dystonia example there. When somebody has dystonia in multiple locations, we call it multifocal dystonias. Now, there are sometimes dystonia also occur like in a leg or neck. So it's kind of like multiple segments, and those are would be multifocal again. And segmental dystonia, when the two parts involved next to each, like shoulder and the neck, and if that's abnormal posture, that's called segmental dystonias. Some patients have one side of the body only involved, and it's called the hemi, like one side, one section, one whole side of the body is called hemidystonia. It's due to structural lesions mostly. So these are the main classification. Now in 2013, we reclassified dystonia into categories such as isolated dystonia, in which the dystonia is the only sign, and then combined dystonia, when dystonia is present with the other sign. It's a similar classification the old-fashioned way, but they had make more simplification in that model. So that's the main things you can classify, and when you examine patients and determine what type of dystonia you're dealing with.
So we see it in Parkinson's, but we also have quite a few people that might be diagnosed with an atypical Parkinsonism like PSP or MSA. So do we see dystonia in these disorders as well? And is it as frequent or maybe even more frequent?
Right. I think before I go on to the PSP, I should discuss a little bit about the Parkinson's patients, what type of dystonia they have. So if we think about the most common type of Parkinson's, we call idiopathic Parkinson's disease. And dystonia in the beginning is not commonly seen. Now there are some exceptions. For example, in some older patients, you see that the foot dystonia could be the first manifestation or first sign of Parkinson's disease, or in young onset Parkinson's disease, sometimes the dystonia is more common than the old onset. And in some patients, you can see dystonia in the hand or in the neck, and is rare. But dystonia happens later in the disease with the treatment, such as levodopa treatments or other Parkinson's medication. It's called treatment induced. We'll discuss later. And so dystonia is not as common in just the regular, more common variety of Parkinson's disease. Now, atypical Parkinson's disease like PSP and MSA, they have dystonia early feature. So if somebody comes to us with early signs of dystonia, significant dystonic features, then we suspect that we may be dealing with atypical Parkinson's. And there are three main common types. One is the PSP, multisystem atrophy, and corticobasal degeneration. The three main Parkinson plus syndromes in which dystonia is very prominent in early feature and resistant to medication, versus Parkinson's dystonia, they respond to the drug fairly well. So that's the main. Now the dystonia manifests different ways. Like for example, in PSP, the dystonia could be in the neck, such as the hyperextension of the neck, and that's very a significant feature where patient neck is hyperextended. They also have dystonia of the fingers and the hand. They can have blepharospasm, where the eyelid, forceful closure of the eyelids. In MSA, the dystonia also involve the neck, but is opposite of the hyperextension, is more forward flexion. We call it anterocollis in MSA patients, which differentiates from PSP. In corticobasal degeneration, dystonia is only involved sometime on the one side of the body and then move on to the other side. So yeah, so multiple different diseases show dystonia. Dystonia itself, as I mentioned, is not a diagnosis. It's just a sign which is there.
One person asked what you would say is an early dystonia in MSA, 1 year, 2 years?
So early dystonia, as I say, everybody is different. Some patients, they present with in 1 year the dystonia of the foot, for example, the toe curling, very prominent, maybe in 1 year of the diagnosis. Some patients, they develop later on the neck dystonia or anterocollis, which is the neck start to pull in forward direction, not in the beginning, but later on, or their trunk, they have, we call it the camptocormia, like forward flexion of the trunk, can also be seen in MSA, but it can also be seen in Parkinson's disease after so many years. So yeah, so dystonia can be early and late, but when it start very early, that is highly suspicious of having Parkinson plus syndrome, such as multisystem atrophy, PSP, and other Parkinsonian syndromes.
Okay. And I had a question that I had come up with when I was doing a little bit of planning in advance. And I know there's different types of dystonias, and we're focusing on Parkinson's, but there was one that came up that was called Dopa-responsive dystonia, which occurs in earlier life. And the question is, we know if a person with Parkinson's can develop dystonia, but can a person with dystonia, such as Dopa-responsive dystonia, that starts in early life develop Parkinson's? Is there any relationship or?
Yeah, Dopa-responsive dystonia is a genetic condition. It starts in a childhood, young age. They have a gene mutation and deficiency of enzyme, which leads to decreased level of dopamine. It's not the condition which progress similar to Parkinson's disease. It's responds very well with the low dose of L-dopa, carbidopa. So like maybe even half tablet once or twice daily make their symptoms significantly better. What they have it is they develop dystonia in their leg where they have trouble with walking. They have very mild symptoms of Parkinson's also on exam. And their symptoms kind of not very progressive. If they get medication early on, they respond well. And they're mostly the children's. It can start a little bit later in life, but not like old age, maybe, like in teen age versus like very early, like a maybe 9 or 10 year old child. Now they sometimes misdiagnosed as cerebral palsy, but when you give them a dopamine, they really respond well. And they have, interestingly, we call them the fluctuation. Like in the morning, they are better. They just walk pretty much normal, and as the day goes on, they get worse gradually, and their symptoms get worse, and we call it diurnal fluctuation. So with rest, their symptoms improve, and they don't progress like Parkinson's disease progresses. So they don't develop the dyskinesia, which is the side effect of L-dopa. They don't develop motor fluctuations, and their course of progression is totally different. Now, sometimes patients with early Parkinson's disease, like young onset or juvenile, which is the children onset Parkinson's, they also misdiagnosed as dopa responsive, but later on they branch off in a way that they have different disease. So their progression is like they develop motor fluctuations, they develop dyskinesia, and so Parkinson's, in terms of having a high risk in dopa responsive dystonia, no, they don't develop Parkinson's disease, but early misdiagnosis happens, and then we can say, oh, this is not dopa responsive, actually this is Parkinson's disease. Now you can do a DAT scan. The DAT scan is dopamine transporter brain SPECT scan, which sometime again is positive in Parkinson's patient, but is negative in dopa responsive dystonia. So it can also differentiate if this is a big question, but they don't develop Parkinson's disease at any high risk.
Okay, so and you've mentioned a few of the types of dystonia people might experience. So I'd like to delve into those a little bit because I've seen some questions that's coming up, but I think that we need to set that stage first. So you mentioned blepharospasm, and you've mentioned some of the folk like the facial. So can you talk about those to start with?
So we are talking about Parkinson plus syndromes like PSP dystonia, or just the regular Parkinson's disease dystonia. You can,
That's
yeah,
regular. Mhm.
regular. Okay. So the regular Parkinson's disease, as I say, early on in Parkinson's disease patient, in the beginning of the disease, the dystonia is uncommon. We can see it in the hand. Maybe in some patients we call the writer cramps. It's rare, but in some patients they develop trouble with handwriting, and dystonia in the hand could be the first manifestation of the common type of Parkinson's disease. And then same thing I said before, that in leg, people sometimes develop this foot inversion during prolonged walking, and they get a little bit, foot dragging, and that could be the dystonic symptom. Also, in some patients, we see the dystonia of the arm, where the arm is start to flex when they walk with decreased arm swing. It go in the flexion posture. That could be the early sign of common dystonia. These patients may not have tremor much. They have mostly in some patients, the dystonia is in the hand in a way that the thumb starts to go up a little bit in extension posture, and we call it a striatal hand. And same thing with in their foot, their big toe also start to hyperextend, and we call it a striatal toe. Um, and then sometimes they have early morning dystonia, where they wake up with the toe curling is painful, and it's called early morning dystonias. So these are some of the patients who may get these dystonia early on, but as I say, it's not very common. Now, in some patients, when they get treatment from levodopa, after 2 or 3 years, they develop dystonia from the treatment. And that treatment leads to dystonia, again, early wearing off phenomena, where the drug wears off and then they get into the dystonic spasm of the muscles. Again, the foot dystonia is common with wearing off phenomena. Early morning, when they wake up, there's no medication in the system, they get dystonia. Blepharospasm rarely can be seen. Now, there are on dystonias in Parkinson's disease we also see. When the dopamine, after so many years you take dopamine, your brain get hypersensitive, and it causes the abnormal postures. And they are actually dystonic dyskinesias. So it's a type of dyskinesia, but they are more sustained and sometimes painful. So the neck may be in most common areas in the neck and limbs in these patients. So that's the treatment-induced dystonias and Parkinson's. So these are the number of different types of the dystonias you see commonly in Parkinson's disease patients. And there are a number of ways to help and treat these conditions.
So, and you mentioned the neck earlier, or torticollis, frozen shoulder, pain in the back, those potentially dystonia.
Yeah, so yeah, some of these, if so, the dystonia by definition is that you need to see abnormal posture. So if somebody complain of just the neck pain, the back of the neck muscles are pulling, it's painful, but the posture is normal, like very neutral and straight. You don't see like tilting or turning of the neck or forward flexion of the neck or hyperextension. Then it may not be just dystonia, just the muscle spasm. When you treat as a muscle spasm, uh, but as I say, in patients with Parkinson's, yes, they can have muscle stiffness due to increased muscle tone. It's just the muscle rigidity. So we're not calling as a dystonic muscle spasm. So that's how we different. We need to see abnormal posture to make a diagnosis of dystonia in that particular case.
And I had someone ask if you could discuss a little bit more in depth the truncal dystonia.
Yes, yeah, that's kind of a little bit complex in a way that there are many causes for truncal dystonias. Let's start with Parkinson's disease first. In Parkinson's disease, the truncal dystonia, the medical term is called the camptocormia, where you see that the trunk start to flex in forward direction, and when you walk, it gets more and more worse. It not happens in the beginning of the disease. It may comes 8, 9, 10 years later in some patients, where when they stand up, they are pretty straight. As soon as they walk, it keeps worse and worse. So they are more activity induced. And when they lay flat, this dystonia goes away and they're pretty straight and when supine position, like laying flat. So that's kind of like a very interesting to see this type of dystonia which goes away in sleep and laying and gets worse with walking. It leads to falls because the center of gravity shifts in forward direction and your posture is abnormal. Sometimes it's the tilt, which is sideways. So truncal dystonia could be tilting of one side or the other. And if you can see some patients, they have leaning, when they sit in the chair, also leads to fall and loss of balance and gait difficulties. So the dystonia of the trunk is common, is an advanced stage, and it can happen in common type of Parkinson's, also happens in PSP and MSA and other Parkinsonian syndromes. Now, trunk dystonia can also look similar in some patients when they have muscle weakness, which is we call the paraspinal muscles, and it can lead to we call drop head, where the paraspinal muscles are weak and they are not dystonic, but just because of the weakness of those muscles, their posture is abnormal. So this is different than dystonia of the Parkinson's, and it can happen in Parkinson's patients also because of muscle deconditioning. In patients who have other types of dystonia, we call it generalized dystonia, particularly in children's. The dystonia start in the foot and goes travel up, and it involves the trunk, it involves the neck and other parts of the body, and we call it generalized dystonia. And this is a genetic condition. And these children also have a dystonia of the trunk, where the trunk goes one way or the other, and they have severe, spasm of the muscles. So that's yeah. So that's you see mainly how these two conditions are differentiated. One is the genetic, and then one is Parkinson's, and one is the muscle weakness, which can cause trunk to be abnormal and posture would be abnormal.
And so, in those situations with weakness and all of that, can therapy and stretching be a treatment for that?
Yeah, so for the Parkinson's dystonia, camptocormia or forward flexion, there are muscles in the abdomen which is pulling, the forward direction. So people have used a Botox injection in muscles called rectus abdominis, on both side, and sometimes it works for like 2 to 3 months and make the posture a little bit more straight because you are relaxing those muscles which are abnormally pulling. Um, but the treatment is again is very limited now. Physical therapy helps, but it's temporary help. If you don't keep doing exercises, stretching, then you go back to the same level again. Some people have done surgeries, putting rods alongside with the spine to keep the posture straight. So there are a number of surgical treatments, but they are a little bit aggressive, and in older patients, it's unsafe to do those treatments with the with patients particularly who have significant stoop posture, which is again it can be done. It can be seen improving. Now, in some patients, they have done DBS surgeries like subthalamic nucleus DBS or globus pallidus internus DBS surgeries, which can help their dystonic posture to some degree. Because after a while, your posture get fixed. If you remain in one posture for a long time, there's a contracture formation where the muscle gets tighter and tighter, and then after that, if you do any treatment or stretching or physical therapy, you cannot reverse it and it gets fixed. So the fixed posture is difficult. If you intervene early with physical therapy and these treatments, yes, there is a potential of improvement, and with exercise and stretching, it maybe keep it at the bay.
All right, I had a question come through that's kind of sort of what you were mentioning, maybe not to the degree of being in a fixed posture, but someone asked, is it dystonia when after leaning forward over a stove for 20 minutes, so it's difficult and painful to stand up afterwards?
So yeah, so dystonia can be painful when you strain muscles by putting too much pressure on. Yes, it may cause pain. Now, pain is not very common in dystonic patients. So other conditions need to be checked, like disc problems. People have a lot of arthritis in the disc or disc herniation. Those can cause pain. So that need to be checked and treated like by injection or surgical intervention. So make sure that if you have significant pain, with the posture, then it need to be like MRI of the spine need to be done to look for other causes. We cannot, say that everything is like coming from that one disease. We have to look for other possible causes, which is more treatable.
Okay, so let's talk a little bit about the treatments. You referenced Botox. So can we get into that a little bit?
Yeah.
When is that appropriate, and is there only certain parts of the body that that's appropriate?
Yeah, no, so Botox is a approved treatment for dystonia since 1992, but not for Parkinson's dystonia. They have recommended this for just the dystonia of the, cervical dystonia or torticollis initially, and then other types of dystonia, which is not related to Parkinson's, but it's been used in Parkinson's quite widely by the physicians. The Botox mechanism of Botox is that when you inject somebody, it blocks the neurotransmitter at the neuromuscular junction where this neurotransmitter acetylcholine has been released. So you block that chemical to relax the muscle. So we know, like for example, patients who have dystonia of the foot, which is very common, as I said before. So there's a dystonia in Parkinson's, which is like very painful. It can cause toe curling or hyperextension of the big toe. It can happen early morning hours. It can happen when patient is on medication. So we have injected those patients. Now we know that every muscle have different functions. So if we know which muscle causing the toe curling, so we go in, we inject Botox in those muscles and see if it relaxes them. And it takes 7 days before it kicks in. And if we're in the right places, yes, it relaxes the muscles, and the Botox effect lasts up to 3 months, 90 days. And then you see the symptoms start to come back, and then you re-inject. So finding the right muscles and finding the right spots, and then identifying which are the main ones, and then inject those with a good dose helps the dystonia in Parkinson's. So we can inject like in the foot. We can inject in the hands muscles where the toe curling, the finger curling, or the arm flexion. We can use the biceps muscle maybe to help that flexion of the arm. Sometimes the trapezius is very tight, or the neck dystonia is there in Parkinson's. Yeah, so depending on the location, finding the right spots is the key for success. And it's been tested, and some patients respond well. Not all of them. I have to admit that. There are some patients, they may not respond to the injections, due to either they are resistant or their dystonia is too fixed. As I say, if the toe curling go too long, then the joint get fixed and there's a contracture formation, then the Botox will not touch it. It will not relax it because the tendons, the joints, they are fixed. You cannot reverse them.
And someone that asked specifically about the use of a toe guard.
Yeah, the toe guard is helpful to put on, and people sometimes they have their different ways to put them in the shoes when they because dystonia and Parkinson interestingly get worse with activity like walking. People that complain that as soon as they start walking, the toes start to curl, or their big toe hyperextend and pushes up and gets painful. So yeah, so toe guards are helpful, and we recommend to go to the occupational therapy program, and they can assess the situation and they can customize, make a brace, for the foot to improve. Some patients have a foot inversion, so there's a brace which they can use to make it foot straight when doing walking. So yeah, so a number of ways to help the dystonic posture using those braces and guards. But I think if there is a physician you work with who has knowledge of Botox, that's what trying it, because you try early on, it helps to relax the muscles and may not cause these higher complications where everything get fixed, and then even with the guard, even with the Botox or medication, you can't change anything there.
So you mentioned some triggers, and someone asked, their spouse has dystonia in the toes, and they say it's triggered by washing their hair in the shower. Is that
So
a possible trigger, or?
yeah, it may not be, but this only in the shower is happening. Could be the water touching the feet. I mean, it's possible. That's maybe the trigger. Usually, I've not heard that. Like this kind of aggravation of the dystonia. Usually, it's like say mentioned the walking, some activity. something touching your feet as a sensory phenomena. Yeah, so things are complex in medical science. It could possible, but this is the first time I'm hearing, so I'm not sure if there's any connection there with the hair washing and dystonia in the feet. So, yeah, it could be possible. Cannot rule that out. Yeah.
And another person asked if a super scapular nerve block help with pain.
Yeah, for the pain, yes, it can help, but it's for the pain. It's not for the dystonia. Dystonia were not helped by the nerve blocks. It's been tested. Nerve root, people have done surgeries on the nerve roots and nerve blocks, but it's mainly for the pain and inflammation. So Botox would be still the mainstay of treatment if it's in shoulder area and the scapular area. But if there's a pain, is it something else coming from like some other neuropathy or a compression of the nerve roots, yes, then this modality will help.
And someone referenced a study that's being done in Korea and Japan showing success in treating cervical dystonia with injections of lidocaine and ethanol combined in some cases with a cervical collar. Have you heard of this study, and do you know if it's being done at all in the United States?
Yeah, we have not done that. I know I have seen the papers on it, these lidocaine and combination of ethanol. Um, Again, if you compare things like in terms of clinical trials, when we used Botox, their clinical trials were done for cervical dystonia patients, and it's highly effective treatment. It improves posture 80-90%, and it has good efficacy. Now with this. I have reviewed a couple of papers on the phenol and lidocaine. It is a transient improvement, but not as effective in terms of the percentage of efficacy, maybe 30-40% effective in these cases. Now, in countries where it's not available, when, widely the Botox, this could be, the treatment can be offered temporarily to relieve the symptoms. However, I mean, in the United States, we have insurance allowed us to do that. That's the reason we have not done the studies on ethanol and lidocaine. So I would say actually the paper which I saw before, it was from Philippines, which I'm talking about, and they have tested for very specific type of dystonia, and they said it's beneficial, but they have not compared with Botox injection head to head. So it's difficult to make the final assessment because in US don't use it. We have not done a clinical trial comparing both head to head, in patients.
And one person asked what type of Botox is best to prevent an immune system resistance. So, is there more than one?
So that they're, in the beginning, in back in 90s, when they have manufactured Botox, the company was Allergan, and their manufacturing process involved a protein in the toxin, and that protein is supposed to protect the toxin and encase it, like in a way that it remains stable in certain environment. So this protein has caused sometimes the immune response in the body where the antibodies develop against the protein, and when you injected these patients, so if you injected 100 patients, 1 or 2% patient have developed those antibodies. So for the next injection, when they got the Botox in the system, your body attacked these proteins and also destroy the toxin alongside, make it ineffective. So your body get resistant to the Botox. It's not dangerous to your own body, but the Botox will not work. So that happened back in 90s. But now with further purification mechanisms, they are using very, very low, small amount of protein now. So those proteins, the big, like a higher percentage, they have removed. So now we're not seeing immune responses. So we are seeing like once in a blue moon that somebody has developed the neutralizing antibodies towards those proteins and toxin. But right now we have three main companies who are making the botulinum toxin A, and one company makes Botox B, and all those have further purification, have cause make the so purified toxin that in my practice I don't see anybody who's resistant who became immune towards Botox. And now in old days, yes, I have seen some patients back in early 2000s and late not like 99 or 98, but now with manufacturing improvement, this is very, very rare issue.
So, Let's talk about some other treatment options. Are there other medications or any other treatments, maybe like DBS, that we could utilize for treatment?
Yeah, so let me start with first is that there are a number of oral medications has been tested for dystonia, as we already discussed that dopa-responsive dystonia respond to the low dose L-dopa carbidopa, and any patient or any child who present with dystonia symptoms, we give them the dopamine first because it's so treatable. We think that we should give them at least a trial of dopamine to just rule out dopa-responsive dystonia. Now there are other drugs, like we call them anticholinergic drugs. That drugs, we also know that in patients who have dystonia, they have increased level of this chemical, which is the acetylcholine, and that blocking it, that may help the dystonia. So when we give them drug like trihexyphenidyl or artane, benzotropine, these drugs are helping dystonia in young children, in sometime in adult patient also. So dystonia can respond. Then we have used muscle relaxants like baclofen or tizanidine. These drugs are also used for improve the dystonic posture. Baclofen can also be used in a pump on the back, where sometimes dystonia involving the leg, that can respond, and in young children's. So baclofen is very effective drug in some cases. Benzodiazepines like clonazepam or Valium has been used in dystonia patient as well. Um, Now, coming to these are the main oral drugs. Now, other drugs which are also effective for dystonia are actually dopamine blocking drugs. So the one category of patients who have respond to dopamine itself, but then there are categories where the drug induced dystonia, like antipsychotic drugs, actually they respond to the tetrabenazine, which is dopamine depleting medication. Now, the surgical options, as you mentioned, is that I mentioned already, they are different targets. The globus pallidus or GPI, which is the structure in the brain, they are the main targets for the dystonia, particularly in the young children's. When they have the whole body generalized dystonia, the globus pallidus internus has been tested and it's pretty effective. These are the children who have genetic types of dystonias. The dystonia which are from the secondary causes, like Parkinson's, Parkinsonism, or due to stroke or MS, multiple sclerosis, and those that don't respond well, but still there is a possibility of improvement. Like I mentioned about chemtochormia, like this forward flexion of the trunk. Yes, dystonia can respond. When dystonia is not fixed, then it is still respond to the surgical interventions like DBS. And subthalamic nucleus for Parkinson's disease can also help dystonic dyskinesias, which is the drug induced. Like, for example, somebody has a levodopa induced dystonic contraction of the neck or toes. When you do the surgery, you can reduce the L-dopa dose, and then the dystonia gets better in that way. So yeah, so these treatments, surgical treatments, are helpful. Everybody is different. As I say, if dystonia is not fixed, then you can help them a lot.
Are there any natural remedies or treatments? Someone asked about CBD or any other types of
Yeah,
non pharmaceuticals.
as a physician, as we rely on the clinical trials, now we have not done anything for dystonia trial on CBD. But as I say, this question being asked every day from patients, it relaxes the muscle, so indirectly it may help to some degree, but not completely take away the abnormal posture. Like rubbing the oil on the muscle, this massage therapy have helped some patients. Even the acupuncture, putting needles and triggers, trigger points can help some patients to improve the posture. So yeah, so I am not against using those treatments. If they help any patients, then they should try it. But as a clinical trial, we can rely on the scientific data. So I cannot support that treatment saying that you should. But everybody's different. So trying massage, using acupuncture, using stretching exercise is all helpful. Uh,
And You mentioned something about this earlier, so I'm going to go back to what the relationship might be between medication timing off and dystonia.
Yeah, so as we all know that when Parkinson's medication you take in the beginning, it works wonderfully well. You get on time, sometimes 6, 7 hours it lasts, and then as the disease progresses, the times start to get shorter. In terms of the effect of the drug. So some people develop, we call it wearing off phenomena, where the drug just drops, and then many symptoms which have been mentioned, and probably you have heard about those happen, but alongside the dystonia can also happen in off state. Like sometimes it's a form of pain, muscle spasm, uh, arm flexion, or toe curling, and or neck dystonias. So multiple different things you can see in off state. Then when you take another dose, it just goes improve. So it just goes on and on all day. And then the second type of dystonia you see is the on dystonia. So it's drug actually on the other side. So opposite effect of the drug, it just start to cause dystonic symptoms. So as soon as the drug affects peak, it's called peak dose dystonias, where the drug itself is start to cause abnormal posture of the neck, arm, or leg. Sometime in some patients, the facial muscles start to pull, or blepharospasm, or jaw muscles. So it's very painful in some patients, and it's called orofacial dystonias in Parkinson's disease. Those dystonias, actually only get better when you cut down the medication dose, versus the dystonia, which is an off state, you have to increase the dose and make the dose interval more closer and shorter. So then, so there's a two different kinds of treatment. So first of all, you have to identify the pattern of dystonia, when it starts, when it ends, if it's totally fixed all the time there, or if it just come and go. Then on the basis of that information, you determine if it's a medication induced, or if it's the medication off phenomena, or is it peak dose, and then you rely on that information to make the plan to help these patients. Now the longer acting drugs are better for dystonia, because those patients, they don't get this fluctuation in on and off responses. So, like dopamine agonist drug like Mirapax, Requip, to add those drugs with L-Dopa sometimes helps to improve the dystonic symptoms, because then you increase the duration of the effect of the drug, and you're avoiding these peaks and troughs. So yeah, and then there are some patients, they have diphasic dystonias. That's interesting that they get dystonia at the beginning, and the dose start to kick in, and then it goes away and then comes back again, and when the dose response start to fade off. So it's called diphasic. So there are three main types of dystonia happens with treatments, which we have to deal with, and then guide the treatment accordingly.
And someone had asked what you would use with a person who has a duopa pump.
So, so what kind of treat? So somebody has a deodopa pump, and they're asking what else we can use for dystonia, or oh,
Yeah.
right. So the deodopa pump actually is a better way to administer the medication, because it's given more a smoother level of dopamine in the brain, that we know is less fluctuation. So it should help dystonia to some degree when they are off dystonias. Now, as I say, you can add dopamine agonist medication like Requip, Mirapax, or Nupropatch, longer acting. They can also, alongside with deodopapam, can help the dystonic symptoms. As I mentioned before, we can use low dose baclofen sometime to help dystonia, but it's not, again, there's a 50-50 chance and may or may not help. And then the Botox treatment still can be used for dystonia in patients who are having deodopa pump. Uh, I know the deodopa pump situation sometimes is tricky, because patients are old and they cannot take the dopamine agonist because of risk of hallucinations. In those cases, amantadine can also help in dystonic dyskinesias, where the drug on like high peak dose dyskinesia or dystonias, you can use amantadine to help to calm it down, and that can be another option in some patients.
And someone had asked earlier, as I'm trying to go back and get everyone's questions to the degree I can, is they wanted to know, how do you differentiate between dystonia in the foot and hammer toe?
Yeah, so if you see, so if there is a hammer toe, it's pretty much fixed, right? So it's not like come and go symptom is already there, it's contracture, and you can see that the joint is kind of a little bit look swollen and it's looking big. So that tells me a little bit that this is a fixed deformity. It could be hammer toe and it's fixed. But then somebody who has dystonia, which is hyperextension of the toe, big toe, and toe curling, and they have more early morning symptoms where the medication is not in the system and they complain of more pain at that time. And when the medication kick in, it helps. That guides me towards that this is a more Parkinson's induced and not fixed and is not hammer toe. But yeah, but as I say, it's just like relying on your examination and medication timings and how long the symptom has been going on.
This is an interesting question. Can dystonia cause a metal knee to fail from separating of the joint?
Can you repeat that again? Your voice was breaking off. Yes.
Oh, can dystonia cause a metal knee to fail from separation of the joint?
Dystonia, yeah, is sometimes this in the knee joints. Dystonia usually rarely be seen in knees, but the muscles, if they are pulling and you see it, they are pulling abnormal direction because, as you say, the direction of the muscles, like sometimes they there's a co-contraction of the muscles. So there are two opposing muscles they are contracting together to cause dystonia. So if when the joint is under that kind of stress, yes, it can cause problem. But in the knee, I doubt that it can pull the metal and cause the joint to fail. I doubt. I don't see that in Parkinson's disease that that would be too strong pull. But I think when somebody has a knee and Parkinson's disease and like artificial knee and metallic knee, they have abnormal way to walk. It was putting abnormal pressure, from walking and center of gravity change. That probably leading to knee to fail more than the dystonia of the knee. So I doubt that would be the main cause for it. If that answered the question, I hope, yeah.
Well, if not, maybe they'll write back and
Right.
clarify additionally. Wait, she maybe the metal knee failure is from dystonia in the foot, I guess. So, like you said, maybe it was cause it altered the gait.
Yeah, it's altered the gait. So indirectly, yes, indirectly, but directly the muscle itself pulling the joint in a different direction. That's really difficult because that require a lot of strength and power there, which I don't think the dystonic muscle can do. But yes, the abnormal postures lead to abnormal pressure, change in the center of gravity, change of weight on the joints leads to definitely a joint problem.
Okay, so another gait related question. Someone asked about freezing of gait. So freezing of gait is a different thing than dystonia,
Yes,
correct?
that's correct. Freezing of gait is different mechanism and is not a dystonia or abnormal posture of the leg give you freezing. It's just that brain is not igniting the gait and your feet stick to the ground. You cannot pick them up. But different mechanism, different sign. Yeah. So I'll not call it dystonia or.
All right. And then someone asked if a pain pump can help in cervical dystonia.
Not to our knowledge, the pain pump should not help. I mean, the pain is the symptom in dystonia. So when the pain is going on, the muscles are inflamed and they actually cause aggravation more. So when you control the pain, indirectly it can improve the posture, uh, but directly is not relaxing the muscles. So pain pump directly will not affect dystonic symptoms, unfortunately. Yeah.
And then someone asked if dystonia can lead to spinal fusion of the neck.
The spinal fusion can only done surgically, where
Yeah,
the
if it can cause it to fail. I'm sorry, I didn't finish reading what they had written.
so the question is that the spinal fusion surgery help the dystonia or cause.
No, that the dystonia caused that surgery to fail after it was done.
Yeah, yes, it's possible because as I said, the paraspinal muscles are very close, to the spine, and if they're still pulling, then the yes. So surgery, yes, it can cause surgical complications. It can cause more pain and abnormal postures. So before somebody contemplate spinal surgery, their muscle need to be relaxed and maybe with the Botox or other treatment modalities, so then they can undergo if they have a disc herniation. Yes, it's possible, and I have seen that.
All right. And another interesting question. Someone wants to know if there's anything as far as food that can help or something they might avoid that could impact dystonia.
Not to my knowledge, I've never seen anything in the medical literature about any particular food aggravating dystonia. So no, I don't think there's any food out there which can cause more dystonic symptoms.
And then there was a couple of questions. One was related to who is actually an expert in dystonia and then where you find one.
So
This
all
is a good opportunity to
yeah,
tout movement disorders.
yeah. So all the movement experts, they supposed to be well versed in dystonia. They should know Botox injection. They can offer the surgical treatments. They can refer patient to the spine surgeons and do MRIs and use different drugs. So yes, so they should be the experts. So if you find a fellowship trained movement disorder specialist in your area and you can check online, then you're in the right place. There are some big academic centers where people do only dystonia research, and I know one of my colleague, he's at Emory University, and he is a fellowship trained in movement disorder. Now he's doing research just in dystonia. His name is Dr. Jinnah. So he is at Emory in Atlanta, Georgia. So there are very unique people out there. And then there's another one is Dr. Mark Hallett. He is with NIH, National Institute of Health in Bethesda, Maryland. So he is another expert nationally in dystonia. But they're all fellowship trained in movement disorders, and they see patients like all of the movement people see. But if you're not comfortable with one movement expert, you can always seek a second opinion and then go from there.
And we actually have on our website a link to be able to find a movement disorder specialist. We have the ones that we've partnered with, such as Dr. Ahmed, but there's also a link to the International Movement Disorder Society, where if you're not sure if there's a movement disorder specialist in your area, you can go to that site and you would most likely be able to find one if there's one in your general area. And you can put out to how far out you're willing to drive if you're searching and there's not one in your immediate city. And someone asked earlier too about if we're going to talk about tremors, and we did have actually Dr. Ahmed speak on tremors just a few months ago, and we do have that also up on our YouTube channel. So ask Rachel if she can also put the link in to that, as well as where to go to find the movement disorder specialist on there. So I have someone else that wrote in real quick. This person is asking, I'm a yoga therapist working with people with Parkinson's. Is stretching and strengthening okay in an area that received a Botox injection?
Yes, there's no problem. Actually, it's very helpful. We always recommend that after 14 to 21 days after the injection, they can start the treatment, because by that time the muscles start to relax. So I would recommend that first 2 to 3 weeks, they just wait to see how the drug effect start to kick in, and then you go from there afterwards. And then you do therapy, stretching, and range of motion exercises.
Okay. And I'm just looking through here to make sure that I've hit the majority of the messages that's come through. Is there any final thoughts that you would like to share with our audience that we didn't cover?
Yeah, I mean, I can summarize a few things here. So I said in the beginning that the dystonia is not itself a diagnosis. It's a sign which present in different conditions. And Parkinson's have different types of dystonia symptoms alongside with tremor or rigidity or bradykinesia. It need to be treated with medication adjustments, and it need to be identified early on. So then we should not run into developing fixed postures in these patients. If it just stay there in that posture long, we get contractures, and then we cannot help these patients. Dystonia respond well to Botox therapy, but in Parkinson's, it's not, it's effective, but it's not as effective as somebody has dystonia without Parkinson's disease. So, but we should try, Botox injection and oral drugs to help, and physical therapy using braces and all these other modalities definitely need to be tried early on and keep the muscles in condition and range of motion exercise going, so then our muscles remains relaxed and not again get fixed. So that's kind of like overall income, covering kind of the treatment and identifying the problem. So I think that should help all of patients who are listening, and see if they can discuss with their physician when they see these painful symptoms.
Mhm. And one question that just came in is, how long can someone receive Botox injections? Is there any like limit to that in
Well,
terms of
I don't.
time?
Yeah, there's no limit to receive Botox. It could be lifelong treatment. As you know that things changes with the time. Sometimes the dystonia start to get better in some patients where the Botox may not be needed, or they go for surgical interventions, like DBS. So so it can be given lifelong. We have patients who receive like 20 years and it's safe. This is a very safe treatment, and there's no limitations to receive it.
And as the disease progresses, if someone, let's say this person wrote in, they were diagnosed with young onset and they've had it for over 20 years with a slow progression. Does dystonia then maybe show up in different forms as the disease progresses?
Not necessarily. The dystonia can involve the other parts of the body. Yes, so if it's a 1 foot or leg, it can go to the other side. Yes, they have progression of dystonia in Parkinson's also. Sometimes people have, as I said before, the neck is totally normal, but after so many years, we see the neck dystonia start to kick in, and so it progresses and it changes the spots where it started first. So there is a progression.
Awesome. Well, we have about 4 more minutes. One person did ask if dystonia is drug induced, do you recommend increasing the medications such as carbidopa levodopa?
So if the drug induced, if the high level of, sometimes, as I say, is a two side of the coin. In some patients, the high dose of levodopa cause dystonia. So we have to cut down the dose and reduce the amount to see if that dystonic symptom goes. So it's a kind of trial thing where patients come and we don't know what is causing the dystonia. We think maybe the higher dose. So we cut down the L-DOPA, and if dystonia start to improve or melt away, that's when on the money there. Now, in some patients, is dystonia due to the decreased level of dopamine, so they need more L-DOPA, and those need to be increased, or we have to add other drug to it, such as dopamine agonist or amantadine, and that can help in those patients. So, again, assessing it, examining patient, getting the right history, the timing of the drug, all these things determine if it's medication induced versus non-medication induced.
So I imagine that having people kind of keep a journal and tracking symptoms and timing and all that would be very beneficial for you.
So give you the example. For example, if somebody wake up in the morning and say, my foot is not, I can walk fine and I have no dystonia of my toes or big toe, I'm normal. But as soon as I take my levodopa after like around like 8 o'clock at 9:30, I have this toe start to cramping and the spasms start to happen. Then I know this is sometimes this is the medication. So I have to think about cutting down a little bit because it could be the peak dose effect causing dystonic symptoms. So see how we get the clues there. Because sometimes, so I ask them, have you have this symptom in the morning before you start your medication? Or it happens later in the day, or happen in the nighttime or early morning hours. So all these things we have to get in the history to really determine that.
Awesome. So the more you have in terms of information, the better.
The better.
You mentioned Valium earlier. One person asked if it is addictive. I think people concerned about, too many meds and things that could become a problem for them.
So Valium is effective for dystonia in young children. It's not as effective in Parkinson's and older patients. So I would say in older patients, you can try like baclofen, low dose, but it make you drowsy, has side effects. So as I say, the oral drugs have side effects of addiction potential, drowsiness, off balance feeling, because you already have off balance. When you're drowsy, you get more off balance. So I would not throw drugs on older patients with Parkinson's disease, the oral drugs. I would definitely discuss the Botox injection as the main modality of treatment, and physical therapy and brace and yoga and other modalities, and DBS in some patients when they are the candidate for it.
And last question,
Yeah.
seizure meds, can they work?
In some patients, there are seizure meds like carbamazepine, or people have used like gabapentin. They have minimum effect on dystonia symptoms. Sometimes, as I say, in some cases we have used it, but again, younger children's, not the old patients. Like in patients with multiple sclerosis, they have respond to carbamazepine. They have get these spasms and dystonia symptoms. So not in Parkinson's though. Epilepsy drug is not very effective in Parkinson's patients.
Awesome. Well, this has been extremely informative, and I really appreciate your time. I want to thank you for joining us, and thank everyone that is on today for joining us for this really great information from Dr. Ahmed. So if we want to give him a wave of gratitude, we thank you so much for giving us your time, and we wish you a good rest of your afternoon.
Thank you. Thank you for inviting me, and hoping to see you in future and discuss many more topics. Thank you again. Bye-bye.
Absolutely. Take care, everybody. Have a good day.